You should enjoy our next session. And I just declare the chairperson of this session, Professor Sufia Rahman, Professor Mir Jamaluddin, who is the Secretary General Bangladesh Institute of Cardiovascular Intervention and Director of National Institute of Cardiovascular Disease, and Professor M. Maksumul Haq, Professor Farooq Ahmed, Dr. Mohammad Jahangir Kabir, Professor Chaudhry Meshkat Ahmed, Dr. Professor M. Liaquat Ali, and Professor Khalid Mohsin. And I really feel proud to introduce my co-moderator, Dr. Mirbat. Now I introduce our discussion, Dr. Ashraful Haq Siam. He is a cardiac surgeon in NICBD, Professor Abdullah Al Jamil, Dr. S.M. Habibullah Selim, Dr. Haripada Sarkar, and our wonderful colleague, Dr. Shakil Farid. He is a surgeon from UK. Now initially he was working in Oxford University Hospital. Now he's working in Cambridge University Hospital. And Dr. Habibur Rahman and Dr. Salma Khan and Dr. M. Anisul Lawal. Sabina Hasham also is present there. And now I will go to the straightway for the first talk. Before going to talk, current left main landscape, how to select best option by Professor David Taggart, UK. All of you know he is a really lion-hearted surgeon in UK, and he is the one of the author of Excel trial. I mean, fortunately or unfortunately, he withdrew his name from Excel trial, but still we believe he is with us, and he is a really real life person to treat the patient, not the disease. So I request, and after him, Professor Imad Shivan will in the line, and also Dr. Marlus Farang from Germany. He is also with us. And my friend, Professor Shaoliang Chen, you know, he's the inventor of the decay crush technique. And really, we are fortunate to have all of the world leader. So let's enjoy our session. Now I'm requesting Professor David Taggart. Please come forward and share your slide.
Thank you, Mr. Chairman. Thank you for the very kind.
Farooq Ahmed and Dr. M. Jahangir Kabir.
Cool.
Both of us, we are cordially invited, both of you, to the session. Professor Farooq Ahmed, Chief Cardiac Consultant and Head of the Department of Cardiac Surgery, National Heart Foundation and Research Institute, and Professor M. Jahangir Kabir, the largest or highest work in cardiac surgery in Bangladesh. He is in United Hospital. Dr. Jahangir Kabir and Professor Farooq Ahmed,
also chairperson.
And those the two are also chairpersons, and we are requesting them to take their chair virtually. Thank you.
Thank you. Can you see my screen?
Yes.
Yes, sir.
Great. Thank you. Well, I'd first like to thank the Bangladeshi Society, Professor Azam, and my good colleague, Mr. Shakil Farid, for the invitation to take part in this very excellent symposium. And also, I know the next speaker is a good friend of mine, Dr. Saban. So what I'm going to do in the next 15 minutes is talk about the landscape for left main disease with respect to PCI and Cabbage. My conflicts of interest are that clinically I'm a cardiac surgeon, but I will try and present the data in a balanced fashion. I would also point out that our unit in Oxford, the cardiologists and the surgeons were the second largest recruiters to the XL trial worldwide, although I will explain why I personally withdrew. And I do have some commercial interests, but none of them relevant to the presentation today. In view of some of the very interesting comments we've already heard at the meeting, I would point out this statement by Marcia Angel, former editor of the New England Journal of Medicine more than a decade ago. Conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published, or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. So bearing that in mind, I want to look at PCI and Cabbage in left main disease. We'll look at some of the key issues in interpreting data. I will speak very briefly about PCI versus Cabbage in multi-vessel disease without left main. Look at the changing perspective of PCI in left main disease over the last decade. Look at the most recent trials of left main. This does not include ischemia because in ischemia, patients with left main were excluded. We'll look at survival data at 5 to 10 years, and then look at the relevance of the impact of syntax scores and the impact of left main location with regards to osteal or shaft disease versus distal bifurcation disease, and then look at the impact of repeat revascularization. When we look at any evidence for PCI or Cabbage, I think there are always three things you have to ask yourself. Are the trial patients typical of what we see in real routine clinical practice with respect to coronary artery disease severity? And the answer is usually no, because the patients are usually highly selected. The second issue to consider is what is the duration of follow-up? If there is not at least 5-year follow-up, it should only be considered an interim trial, because what we always see is that with increasing length of follow-up, there's increasing benefit of Cabbage. And the third thing to ask yourself is what was the use of guideline-directed medical therapy? Because it is always substantially inferior in Cabbage patients compared to PCI patients. So the benefits of Cabbage would be even greater if Cabbage patients received best medical therapy. I want to show one slide of Cabbage versus PCI for multi-vessel disease. In other words, no left main disease. Cabbage unquestionably improves survival. It reduces myocardial infarction, the need for repeat revascularization. Its benefits are exaggerated in patients with diabetes and impaired left ventricular function. And the only potential downside for Cabbage over the long term is a small, perhaps in the region of 1 to 2% increased risk of stroke over 5 years. If we turn to left main disease and go back to 2008, we can see at that time Cabbage was considered to be the optimal revascularization strategy for patients with left main disease. And that was due to the fact that up to 90% of patients with left main also have multi-vessel disease, where Cabbage already offers a survival benefit, and that up to 90% of left main are distal bifurcation lesions, which are at very high risk of restenosis. We did, however, point out that there were excellent PCI outcomes for isolated osteal and mid-shaft lesions. In fact, they may have been even better than patients undergoing Cabbage. However, shortly after we published our paper, S.J. Park and colleagues from Seoul Medical Center published the main COMPARE registry, over 2,000 patients, in which they suggested that the outcomes of PCI and Cabbage were relatively similar for patients with low severity left main disease, except for the risk of increased revascularization in patients undergoing PCI. When we then look at the results of the syntax trial, in whom 705 patients had left main, we can see a very clear difference in outcome between those patients who had syntax scores below 32 and those above 33. In fact, this was then used to define the entry criteria to the EXCEL trial. If you look at EXCEL, it is the largest, most definitive trial of PCI versus Cabbage in left main. But bear in mind that it was selected patients with syntax scores below 33. Only 1,900 patients of the initially proposed 2,600 were actually randomized. So the trial was stopped early without any clear explanation of why. Bear in mind again that the mean age of the patients was 66 years, so a life expectancy of 15 to 20 years on average. And the primary outcome was death, MI, and stroke, but not revascularization. And as I've emphasized, Oxford was the second largest recruited worldwide to the EXCEL trial, showing a serious commitment to ensuring this trial was completed. Although for the reasons I will outline, I withdrew from the final publication. There are and were 4 major concerns in the EXCEL trial. The first was interpretation of the mortality data, which was eventually described as one of 20 underpowered secondary endpoints. But to all of us in routine practice, mortality is the most important outcome. There was a persistent failure to initially publish the protocol specified myocardial infarction data, although this occurred 8 months later at the insistence of the editors of the New England Journal of Medicine. There was a change in statistical analysis in the Excel trial from non-inferiority at 3 years to superiority at 5 years, which actively disadvantaged the better outcomes with Cabbage. And there was failure to share trial data, which is very unusual if there is a legitimate request to do so. And the controversy about the Excel trial extended from the medical into the public domain. The first and most important concern of the Excel trial was the excess and accelerating mortality in the PCI group at 5 years. And if you bear in mind that these were relatively young patients with a mean age of 66 years and with low or intermediate complexity disease, this was clearly worrying. And this was accompanied not only by an almost 40% increase in that death rate, but by a significant increase in non-procedural myocardial infarction, the need for repeat revascularization, and there was no difference in stroke. The initial review of the manuscript by the New England Journal editor wrote, "The findings of a higher mortality rate in one group than another in a clinical trial, unless the difference is clearly trivial, should receive central emphasis in the report of the results, and we would generally consider it important to include such information in the concluding statement in the final paragraph." But when the manuscript was finally published, it simply stated, in patients with left main coronary artery disease of lower intermediate anatomical complexity, there was no significant difference between PCI and Cabbage with respect to the rate of composite outcome of death, stroke, or MI at 5 years. And I do not think that conclusion fairly reflected the key findings in this manuscript, and being unable to convince my co-authors of that, I withdrew my name. If we look at what the myocardial infarction data eventually showed, it showed that if you used the third universal definition of MI as specified in the protocol, then there was a 3/4 reduction in the incidence of the new biochemical definition of MI, which had been chosen to drive the primary outcome of the manuscript. In other words, with the standard definition, Cabbage would have been clearly superior at 3 years. And indeed, in this analysis by Mario Gaudino, looking at what happens when you exclude this new unproven biochemical definition of MI, Cabbage is then a clear winner for the composite endpoint and for the individual components of death and non-procedural or real myocardial infarction, and indeed for repeat revascularization. If we look at the Noble trial of over 1,200 patients published in the Lancet in 2016, these patients were the same age as in Excel, but they had a lower syntax score at 22 and a lower instance of diabetes. But overall, this trial showed a highly significant reduction in the composite endpoint and indeed of the individual components of mortality, MI, and revascularization. And interestingly, and probably by play of chance, showed an increased risk of stroke in the PCI group. There have been numerous meta-analyses of the trials of PCI and Cabbage in left main disease. This is probably the most widely quoted, published in the European Heart Journal in 2020, claiming no difference between PCI and Cabbage. This manuscript was written by 14 authors, mainly eminent cardiologists with no surgeons. And what it effectively did was it diluted the largest, most definitive trial of left main, the Excel trial, with 4 older, smaller, weaker studies until the mortality benefit of Cabbage in Excel disappeared. And what was astonishing about this paper was its speed of publication. It was 11 days from the initial submission to review by the reviewers, to revision by the authors, to resubmission by the authors, and then for final acceptance in an 11-day period. However, there are other interpretations of all the evidence of PCI and Cabbage in left main. This is the most definitive by James Brophy, published in JAMA Internal Medicine, in which when you use Bayesian analysis, the most reliable form of meta-analysis, he showed that whether based on Excel results alone or on the totality of available evidence, PCI was associated with inferior long-term results for all events, including mortality, as in comparison to Cabbage in left main coronary artery disease. And in this analysis that I've already referred to by Mario Godino and colleagues, showing that in patients with syntax scores below 33, in other words, for intermediate or low severity left main disease, Cabbage does have a survival benefit. This is a follow-up study of syntax, extended syntax trial out to 10 years, showing that the initial benefit of Cabbage in these patients with relatively low or intermediate complex disease remains for Cabbage out past 10 years. In this very important paper by S.J. Park and colleagues, looking at the effects of location of left main on survival benefit, in the main compare registry with almost 600 patients followed to 12 years, it showed very clearly, as we knew before, that for distal bifurcation left main disease, there is a significant increase in mortality, overall MACE, and repeat revascularization in patients with distal or bifurcation disease compared to those with ostial or mid-shaft disease. And although it's often said by cardiologists that repeat revascularization is a benign event, well, it's not. If you look at the Excel trial and look what happened to any patients requiring repeat revascularization, you can see that in the PCI arm, below 30 days to 1 year, and beyond 1 year, there was a significant increase in mortality of patients undergoing repeat revascularization because of PCI. Now, I think it's very important to finish with an old slide, which is the 3 reasons why Cabbage has a survival benefit over PCI for most patients with multivessel and left main disease. And the first reason is that anatomically, by placing bypass grafts to the mid-coronary vessel, you not only deal with the proximal culprit lesion, but you also deal with potentially vulnerable plaque lesion in the proximal coronary circulation. PCI does not do this. The second difference, as shown by Tom Lusher in the New England Journal more than 3 decades ago, is that an internal mammary artery elutes nitric oxide into the coronary circulation and reduces the risk of further disease. In contrast, a drug-eluting stent impairs re-endothelialization, causes downstream endothelial dysfunction, and creates a prothrombotic environment. And in many patients, PCI still means incomplete revascularization, and this has been repeatedly shown to increase the risk of subsequent mortality and MACE. And I think these are the 3 reasons that PCI, despite its technological advances over the last decade, is still unlikely to ever match the results of Cabbage for most patients with left main and multivessel disease. If we look at the current ESC-EACTS guidelines for treatment of patients with left main, we can see that 2/3 of patients have syntax scores above 33. For all categories of left main, Cabbage is 1A. For patients with intermediate left main disease, 23 to 32, PCI is a class 2A consideration, meaning it can be considered. But in view of the Excel results, we need to reconsider whether that's the right classification. And for patients with left main above 32, then it's a class 3 indication for PCI, meaning don't do it. If we look at the similar outcomes or recommendations for patients with multivessel disease, 80% have syntax scores above 22 and have a class 1A indication for Cabbage. And those benefits are extended in patients with diabetes. And I would argue that for Cabbage, if there were more arterial grafts and greater use of medical therapy, then those benefits of Cabbage would be even greater. So to summarize, for multivessel disease without left main, Cabbage is clearly superior for all classes of syntax scores, and especially in patients with diabetes and/or impaired ventricular function. For left main disease, Cabbage is clearly superior for syntax scores above 32. In the Excel trial for patients with low or intermediate disease, Cabbage had a clear survival benefit. And for the Noble trial, again, Cabbage showed significant reduction in non-procedural MI and repeat revascularization. There is conflicting evidence about the mortality data for PCI and Cabbage in patients with low or intermediate severity followed out for 5 to 10 years. But in this situation where there is ostial and mid-shaft lesions, PCI can do very well. In contrast, there's a clear survival benefit in patients with left main with distal or bifurcation lesions, accompanied by a significant reduction in procedural MI, in non-procedural MI and repeat revascularization. And repeat revascularization is a clear predictor of increased mortality. Repeat revascularization is not necessarily a benign event. My personal view is that the current data still suggests that there should be a cautious approach to the use of stents in patients with low or intermediate severity left main disease, and especially in those with distal bifurcation lesions, and especially in younger patients with an anticipated long life expectancy. And finally, in addition to thanking the organizers for the great privilege of taking part in this meeting today, and the audience for your attention, I would like to welcome you all to the International Coronary Congress, which will be held in New York in December this year, hosted by myself and my colleague, John Puskis, and you're all very welcome to attend. On that point, I'm going to conclude my talk, again thanking the organizers for the opportunity to make this presentation. Thank you.
Thank you, Taggart, for a wonderful and brilliant presentation. Now I am just asking our panel or any participant. I show Professor Chaudhry H. Hafiz Ahsan from Las Vegas. Would you like to make any comment?
Yes, thank you, Professor Taggart. You know, this is sometimes with the interventionalist, we are too much in ego and don't appreciate what is best for the patient, rather than we just think about what we can do for the patient. And we need to be realistic. But my question to you, and the data clearly show in many cohorts, as you pointed out, that Cabbage may be superior, and we really need to give a proper hearing from the surgical side when we talk about heart team approach. Sometimes I see that we don't give a fair hearing. But my question to you is, what about in acute coronary syndrome? And in acute coronary syndrome and cardiogenic shock, I think in that situation, we don't have enough data, and we may be thinking even more about the heart team approach.
Yeah, thank you for your kind comments, Dr. San. There is no question that in the situation of cardiogenic shock, the best friend of the cardiac surgeon is the interventional cardiologist. There is no question in that situation that PCI is the best option to try and get the patient out of immediate trouble. I think for most acute coronary syndromes, it should be dictated by what the ventricular function is like. If you still have good LV function, then in our center in Oxford, most of these patients would still be treated as for elective coronary artery disease. So I think the decision in the acute setting comes down to that question. What is the LV function like?
Can I have a question, please, Dr. Ajong?
Yeah, Pradeep. Okay,
Yes.
yeah, okay. You proceed, please proceed.
Thank you very much, Dr. David, for your nice presentation.
Thank you.
Yes, I have some query. Actually, there is three subject of interest. One is left main, another is the Cabbage, another is PCI. In the study, the PCI definition includes the balloon angioplasty to stenting and the optimized PCI. But there is a clear benefit, a balloon angioplasty and stenting, and in the stent, there is first generation, second generation, even in third generation, it is much more superior. Even now, most of the patient is optimized PCI by the image guided. So even in the Cabbage situation, all the Cabbage not means Cabbage. If there is some arterial Cabbage and there are some venous Cabbage and there are some mixed Cabbage. all the Cabbage situation does not imply same modality or same morbidity benefit. So, and even in the left main cases, all the left main does not mean left main ostial, left main shaft, left main distal. Even there are some situation in the ostial and in shaft, the syntax score is most of the cases, if no other involvement, less than 18, even is less than 32. So there is definite benefit, even the equal benefit in less than 18 syntax score in the class 1 indication. So it is not a straightforward line that all the left main cases CBs is beneficial. My thought, the left main disease.
Pradeep, what is your question, Pradeep? What is your question? Actually, he rightly mentioned low
Yes, left
syntax
main.
score can be as
I understand. My thought is all the left main should not be treated as benefit by the CBZ, should be individualized.
So thank you for your kind comments. I thought I showed the data, so I completely agree with you. I showed the data. I think for osteal and mid-shaft left main, the results of PCI are excellent. They may be even better than Cabbage. So I tried to show that. But for distal bifurcation lesions, it's very different. The second point I tried to emphasize was the cardiologist must stop always saying we now have a new stent, because Cabbage is not to do with the stent technology. Cabbage was better than balloon angioplasty, is better than bare metal stents, is better than drug-eluting stents, and it's because Cabbage is doing a different thing from what the stent does. They are different pathophysiological mechanisms.
this is more natural. Now I'm requesting Dr. Shakil for it. Do you in line, Dr. Shakil?
Yeah. So thank you, Prof. David Taggart. You have very elegantly shown the controversies regarding the treatment of left main. I've listened to this talk many times, and I can tell you that I never get bored to the talk. It's such an amazing talk. So I have two questions to you. First is, you have clearly alluded the influence of the industries in this kind of studies. We have seen with the TAVI trials, we have seen with the Excel trial, and we know many of the key people are involved in very influential positions in the industry of the Excel trial. Where is the clinical governance for this? Is there any fallout following the Excel trial? Is there any way we are going to change these things in future? This is one thing. Second question is, the last EX and ESC guideline was published in 2019, joint guideline. Is there any plan to publish a new guideline in following the results of the Excel, Nobel, and other trials? Because I think that is very important for rest of the world. I mean, we have very good heart team approach in many parts of the Western world, but in a lot of countries it doesn't exist. So where is the plan to establish that? Thank you, Titi.
So great questions. Thank you, Shakil, and thank you again for the great privilege of taking part in your excellent meeting. So I think the two things, so very soon we will hear the updated ACC AHA guidelines, which I know are in their final format. I have no prior information. So it'll be very interesting to see how the ACC AHA deal with Excel and Nobel. I think with regards to the conflicts of interest that exist for doctors, we're no different from anyone else in reality in life. And I think the reason I started my lecture by quoting the former editor of the New England Journal of Medicine, I think that quote from a decade ago tells us that all those perverse conflicts of interest, I mean, we've heard many of your very good speakers today already talking about conflicts of interest in terms of how patients are treated. But the truth is, unless, I mean, as you know, Shakil, and you've referred to, in Oxford, we have superb heart team meetings where our cardiologists and surgeons are completely committed to making sure we offer the best recommendations. But I think we are unusual. And when I give lectures around the world or visit different countries, what we do in Oxford would still be unusual compared to what's happening in most other parts of the world. But the answer to your question is essentially, unless doctors are committed to being part of heart teams and doing the right things, then it's impossible to see how you can resolve this.
Thank you, DT.
Thank you.
Thank you, David and Dr. Shakil. Now I'm requesting Dr. Syam. Are you in line, Dr. Syam? Or any, I take one more question from anyone volunteer. Chaudhary Mashkad Ahmed, sir, are you in the line?
Thank you very much. Thank you very much. We have to keep in our mind the hard fact about the outcome of primary PCI, which has shown us that there was no reduction in incident of heart failure, even primary PCI doing other than left main disease. This is one of the important information that should supplement the whole debate, that till date, we could not reduce the rate of heart failure in primary after successful primary PCI. This is one point. My question to David, sir, do you think the test, the inferiority test, which has got obviously some slippery slope in the whole process, do you think still those inferiority tests will really make good judgment of the whole clinical trials?
Well, it's a very good question. And I think it comes back to if you look at PCI versus medical therapy outside the setting of a non-STEMI, there is no evidence PCI has any advantage over optimal medical therapy. Every single important study has shown the same thing. So I think outside the setting of STEMI, there is actually no real evidence for the use of PCI in elective or urgent patients. I think that's different because I think in the Cabbage population, it generally deals with patients with more advanced coronary artery disease. So I do not think PCI and Cabbage are equivalent therapies.
Okay, thank you, David.
Thank you.
Professor Ajam, can I have a question, please?
Sorry.
Professor Ajam, may I ask a question to Dr. David?
Sure, please. You make a very small question, not big question, no?
Yeah, okay. Professor David, I'm a cardiologist, actually. From a cardiologist point of view, I want to ask you that there's no doubt in LV dysfunction, CABG is definitely a better option for a long-term. Yeah, but in our country, some of the surgeons, they are reluctant to operate patients with LV dysfunction, and they are testing the N-terminal pro-BNP in patients and saying that this patient is not fit for surgery, and they're deferring the operations time and again. And the patient's coming back to the cardiologists, actually, because a patient with 4 blockage with an ejection fraction of 40, there cannot be a normalization of N-terminal pro-BNP. So would you like to make a comment on this?
Well, it's a very good point that you're making. And what I would say is if you're the cardiologist and you clearly understand the evidence and you send the patient to a surgeon who says, well, I won't operate because the ejection fraction is 40%, then the best thing to do is, so if that was your mother or father, what would you do? You'd send them to a surgeon who you know would operate and who has good results in that setting. Because ultimately, as the gatekeeper, you have a special responsibility to make sure the patient does get offered the best therapy.
Thank you, David. Before going to next speaker, one of our fellow is make a question. Dr. Aisha Kadir, are you here?
Yes, sir.
Can you raise your question?
Yes, thank you. And Professor Taggart, I'm a very junior cardiologist with an interest in trials. So very interesting comments regarding COI and ties with industry, but realistically speaking, how do you suggest these conflicts of interest be reconciled? Because for interventional cardiology especially, innovation goes hand in hand with working closely with industry, and invariably these are people who will be involved in designing guidelines eventually. So what do you think?
So Dr. Cater, so thank you. It's a very good question and a very important question. And the simple answer is heart teams. If you as an individual doctor, you can convince a patient to do anything or to accept any treatment, it's very easy. But if you have to sit at a heart team and convince the other doctors to do the wrong thing to a patient, that's impossible. So my view is that the government and all people who pay for interventions should say, we will not pay for an intervention unless it's agreed by a heart team. And if it is not agreed by the heart team, then there should be clear reasons why the recommendations have not been followed. So the simple answer is heart team recommendation rather than individual doctor.
Thank you very much, David. And I just take one question from our cardiac surgeon. I
have a
asked
question.
earlier Dr. Siam, he is not available, but I'm requesting Dr. Farooq or any surgeon from Bangladesh.
I have a question. Ajam bhai, I'm
Oh
Dr.
yes,
Siam.
Dr.
I have a
Siam.
question.
Okay, fine.
Okay.
This is my final question. Okay. Okay. Fine.
Yes. Is very happy to see Mr. Taggart and Shakil Farid bhai on this session. It's a very good session, and I heard the topics. Now I have a question. What is the main scoring system for decision making in left main disease? Which it should be PCI or it should be Cabbage, number one. And is there any benefit for the heart team? Collaboration with the heart team?
Yes, so I have just tried to explain that the best thing about the heart team is it means you will get the decision for recommendation. You're far more likely to get it correct if it's agreed by a team of doctors than by an individual doctor. And in terms of scoring systems, they're the general scoring systems that would be any coronary artery disease, mainly a combination of syntax score plus patient-related factors.
Okay, thank you.